Hey everyone, it's Dr. Simone, your favorite podcasting radiation oncologist, bringing you the next episode of Pipettes to Patients, a podcast focused on how cancer research starts in a laboratory and ends in the clinic. So on the last episode, we talked a little bit about the logistics of basic science research, including costs and space as a serious strain on moving cancer research forward. Today, I want to touch on something that Dr. Villapiano really emphasized on the last episode, which is the scale-up that's required to move new discoveries into the clinical space. This is particularly relevant to this month's cancer focus, which is uterine cancer, as June is Uterine Cancer Awareness Month. I want to give you a few quick facts about uterine cancer before I bring it back to why the scale-up of laboratory discoveries is so important in this type of cancer. Uterine cancer is the most common gynecologic malignancy in the United States and most high-income countries across the globe. Typically, uterine cancer presents in women who are over the age of 50 who have gone through menopause, and the most common symptom is postmenopausal vaginal bleeding. There are two major subtypes of uterine cancer: endometrial cancer, which starts in the inner lining of the uterus, or uterine sarcoma, which is a bit more rare. One of the major risk factors for endometrial cancer is obesity, which is on the rise, and unfortunately, so is the incidence of endometrial cancer. An estimated 67,000 patients will be diagnosed with uterine cancer in the U.S. in 2025, with around 13,000 deaths expected to result from the diagnosis. Over the past 15 years, there has been an explosion of data in the molecular diagnostics space. Molecular diagnostics and precision medicine sound really high-tech, but what this means is looking closely at the genetic makeup, or blueprint, if you will, of a tumor in order to understand how it will behave and what treatments it may respond best to. Believe it or not, although we tend to lump cancers together in categories based on where in the body they occur, not all cancers in the same site behave the same way. This kind of testing has been around for years, and it's still not necessarily readily accessible to everyone in the United States, let alone other parts of the world. In order for this to happen, the testing has to be reliable, fast, and affordable. The results also have to be easily interpreted by clinicians in order for this testing to have a meaningful impact on patient care. Uterine cancer is one of the unique sites of disease that is typically treated first by a surgery to remove the cancer, and then decisions are made on what additional treatments are needed. Here's where precision medicine can have a real impact. By understanding the genetic makeup of a woman's uterine cancer, we can tailor treatment recommendations to how we believe the cancer is going to behave. On today's episode, I have the pleasure of bringing together Dr. Allison Roy, an assistant professor of obstetrics and gynecology here at Upstate, as well as Dr. Jeffrey Ross, who is the Jones-Rohner Professor of Pathology, Urology, and Medicine at Upstate, as well as the founding strategic advisor and medical director for Foundation Medicine. We're going to have a great episode on molecular diagnostics and how it impacts uterine cancer treatment. All right, so for the second episode of Pipettes to Patients, I'm here with Dr. Allison Roy, a gynecologic oncologist here at Upstate, and Dr. Jeffrey Ross, who is a pathologist here at Upstate. I'm going to have you guys do something different this time. Why don't you introduce yourselves and give us your title, a little bit of your background?
Sure. So I'm Dr. Allison Roy. I'm like I said, GYN oncologist here at Upstate. I've been here almost 5 years at this point. I came from Pennsylvania, so I did a lot of my training down at the University of Pennsylvania, and then came up here as my first job, and I've really loved it so far.
And Dr. Ross?
Sure. I'm trained in Boston at Massachusetts General Hospital quite a number of years ago, and was the chair of the pathology department at Albany Medical College until 2017, where I moved here to Upstate at the recruitment of both Doctors Corona and Breslovsky. And my area of interest has been molecular pathology particularly, and the development of diagnostic tests that could guide cancer patient treatment.
Yeah, so I think that's something that we're really going to touch a lot on today because it's very, very relevant for uterine cancer. June is National Uterine Cancer Awareness Month. There's a few social media campaigns out there. I don't know if you guys know about them. There's a hashtag Jump for June. I'm not going to make you guys do that with me, but just think about that for your social media posts. So we were sort of talking a little bit before, we started here, but I feel like I'm in the presence of a celebrity, as, Dr. Ross is actually the founder of one of the founders, right? So of Foundation Medicine, a company that focuses on molecular diagnostics, which is really a game changer in the world of cancer. I remember being, in residency and using some of these new things and just thinking, wow, this is like really going to change the game for people. Can you give us a little insight as to, how it came about? What was the process of starting that company? And briefly.
It is quite an interesting story, and indeed it does involve celebrities. Goes back to the unfortunate illness of the founder of Apple, Steve Jobs, who was suffering from metastatic neuroendocrine pancreas cancer, widely, known in the public media, this problem. And a good friend of his, Bill Gates from Microsoft, went to Boston to meet with Eric Lander, the director of the Broad Institute of MIT, wanting them to try to help. And what had happened was they developed a genomic sequencing capabilities, but only for fresh and frozen samples, and had never used the classic clinical material, formalin fixed, paraffin embedded. And Steve Jobs passed away. And Eric Lander then went to a venture cap group called Third Rock Ventures in Boston, all of whom had been co-founders with him of a company called Millennium Pharmaceuticals that I had worked at on a sabbatical in the year 2000. And so I had met and become close with all of them, including Eric. And in 2009, they decided that they wanted to put $50 million into starting a company that would actually do sequencing for direct patient care and selection of best therapy, and asked if I would co-found as the experienced pathologist who had run companies and understood all of the rules about CLIA and New York State Department of Health certification, that type of thing. So I embedded as eventually as an employee rather than just a founder. And we started Foundation Medicine officially in 2010.
So I want to go back to something that you just mentioned, the formalin fixed, paraffin embedded. I think a lot of people listening to this are not quite going to understand what that means, but it's very relevant in this scenario, right? With uterine cancer. One of the things that's nice about uterine cancer is the first step is typically surgery. So patients have their cancer removed, which, mentally a nice feeling for patients, right? They can have their cancer out. So Allison, tell us a little bit about what that surgery entails, how is it done, and then what happens to that tissue once it leaves the OR?
Yeah, so most often for endometrial cancer, our surgery is going to be total hysterectomy. So taking out the uterus, the cervix, both tubes, both ovaries. And then depending on kind of preclinical factors, we either do a lymph node dissection or what's called a sentinel lymph node dissection, where we kind of inject a dye into the cervix that maps to kind of the first draining lymph node on either side of the pelvis. Or sometimes we end up doing a whole pelvic lymph node dissection, kind of depending on some of the clinical factors. And that gives us staging for cancer. And so we then send those specimens down to the pathologist where they get processed and looked at to give us more clinical information and some of the molecular information that we use in treating patients.
So you guys get the tissue and then what happens? Something magical happens down there.
Yes, the tissue is placed in a worldwide substance called formaldehyde, shortened formalin. It's been available for more than 100 years. And it turns out to be especially useful because it cross-links the DNA that's in the cancer cells and the benign normal cells and stabilizes them for evaluation. So it's a very, very good, what we call fixative or hardening material to allow DNA to be extracted and studied. It's placed into what's a liquid wax called paraffin, which hardens to create a wax-like block, like a candle, except in the middle of the candle is a piece of that uterine cancer tissue. That sets it up for the specialist in the histology lab, the histotechnician, to slice it very, very thinly and then stain it with two classic dyes, hematoxylin and eosin. Hematoxylin is a chemical name, and that's the blue color which binds to DNA and gives the nuclei of the cells a blue color. Eosin is a much more provocative name because that's a very pink color, and the name comes from Eos, the goddess of the dawn. Oh. And remember, rosy-fingered dawn? That rosy color is actually the color of eosin. And so the developer of the dye named it after the goddess Eosin and calls Eos and calls it eosin. And that's the standard of care, and that's how the diagnosis of cancer is made. But more sophisticated testing, molecular testing, sequencing of the DNA, that comes after the DNA itself, and sometimes the RNA is taken out of that paraffin wax block and evaluated by some kind of a sequencing assay.
And so, the tissue goes to you guys, you look at it under the microscope, and then you report out certain factors based on whatever type of cancer. Right now we're talking about uterine. So Dr. Roy, Allison, can you tell me what are some of the things that you look at when the pathology report comes back to you? I think patients, now with MyChart and everything's available to them, they see all these words and things are confusing to people. So can you shed a little light on that?
Yeah, so there's a couple different things we're looking at on the pathology report. So kind of the first thing we're looking at is what parts are involved with cancer. So where's, anatomically, where is the cancer spread to? Does it involve the uterus? Does it involve the cervix? Has it gone to the fallopian tubes, ovaries? Has it gone to any of those lymph nodes that we've taken out? And that kind of gives us a general stage of the cancer. And then we're also looking for kind of what type of uterine cancer it is, because there's a couple different types of uterine cancer. So the most common is something called endometrioid type uterine cancer. And then that gets split even further into kind of categories of something called grade of the tumor. And so the grade is kind of how abnormal does it look under the microscope, and Dr. Ross can certainly tell us a little bit more about that. But it's basically looking at, how much of it looks like your kind of normal architecture of endometrial tissue versus more solid sheets of tumor cells that don't, have that preserved architecture, and that gives us a grade. And then on the other side, we have kind of 3 different types of uterine cancer that we consider more of like high-risk histologies or high-risk types. And those would be something called serous, something called carcinosarcoma, and something called clear cell. And they have various characteristics under the microscope in terms of how they look to kind of define, which category they fall into.
And then one of the other things, that's particularly relevant here is we've touched on it, obviously, but molecular diagnostics. I mean, that essentially can change the game for patients in terms of what treatments they need after, right, the hysterectomy, because not every patient is done after the surgery, right? So, Allison, can you tell us a little bit about, what are some of the things that we think about after, the hysterectomy is done in terms of defining additional treatments patients might need?
Sure. So, in addition to some of the stuff we've touched on already, whether you fall into one of those higher risk categories or subtypes of cancer versus the endometrioid, and then something else that we look at is something called lymphovascular space invasion, which is basically microscopically looking out at that uterus. Do you see tumor cells in the lymphatic channels? Do you see tumor cells in the blood vessels, to kind of give us an idea of kind of risk for spread of that tumor? And so we're kind of taking the anatomical staging. So what anatomical locations has that spread to, in addition to kind of those risk factors. So the lymphovascular space invasion and the depth of invasion. And then now we're adding kind of another kind of category of risk. So we look at some things like P53 mutation. We look at some newer studies are looking at something called POL-E that kind of give us a little bit more molecular information of, how high risk is this tumor. So P53 kind of edging it to a more high risk, whereas a POL-E mutation actually making it a little bit lower risk in terms of determining, do we need additional radiation? Do we need chemotherapy to kind of treat the cancer to keep it or, help prevent it from coming back?
So P53, Dr. Ross, do you want to explain
Sure.
what
Sure.
what P53 is? I mean, those are just
sure. Happy to do that. Just as a quick overview before, I think people listening should remember that For the most part, endometrioid cancer of the uterus is a very curable disease.
Yes.
These patients are easily treated successfully by the gynecologic oncologists. Where sequencing comes in and issues of whether POLE or sometimes we call high tumor mutational burden or microsatellite instability,
Wow.
one group of uterine cancers that respond to immunotherapy vigorously versus, we call it TP53, tumor suppressor 53, but P53 is his historic nickname, is critical for, it's very much mutated more frequently in these high-risk subtypes, like the clear cell and the serous. And when you see it, that alerts you, could this be that? And it starts to say, well, maybe the pathologist didn't call it, but the molecular findings are really suggesting it, and we want to be more aggressive. But for me, what's I found the most exciting is, at least recently, is the further development of how immunotherapy can lead to wonderful outcomes for patients diagnosed with endometrioid uterine cancer. And it's getting used in new ways. When it first developed, we only used it for people with what we call clinically advanced patients whose lives were at great risk. It was beyond surgical cure. But now we're starting to think about what about using it in a neoadjuvant setting before surgery, the immunotherapy? What about using it in an adjuvant setting after surgery instead of radiation? Because we've had many decades of radiation for uterine cancer and seen many cured women 20, 30 years later developing cancers in the radiation field from so many years ago. So it might be nice to avoid it if possible.
Yeah, that's a really important point. I think that's one of the things that at least I do try to counsel my patients very heavily on, is that even though we use radiation to treat cancer, it's the same thing with chemotherapy, probably to a little lesser degree, right? Is that these agents can cause a secondary cancer down the line. And so it's really, really crucial for us to understand who are these patients that can avoid these potential treatments that have real long-term implications, as you said, in a curable disease. So that brings me to one of the trials that we actually have open here, at Upstate. It is called, very apropos, the TAPER study, and the other part of it is called Rainbow Blue. But basically using molecular testing to further define which treatments are needed for patients. And the really cool thing is that patients that have this POLE mutation, right, they get to be observed instead of offered adjuvant radiation therapy. So, Allison, can you tell me a little bit about what it's like counseling a patient on a de-escalation trial? What are some of the things that you highlight for patients?
Yeah, so when we're talking about de-escalation trials, so we're talking about, here's our standard of care radiation that we give to this patient, and now we're saying, well, with this mutation, maybe we don't need to give the radiation. And, I think it's important to emphasize kind of some of the data that we have leading up to that to say, why do we think that this is appropriate? Because, patients are often fearful of like, am I not going to treat my cancer all the way? Do I need to be doing this? And so kind of, giving them the understanding to say like, look, okay, this is what we've seen so far in kind of looking back at patient populations, doing retrospective data and kind of seeing that, okay, these patients, in ones that weren't treated, they actually seem to do just as well as the patients that were treated. And so kind of making sure that they understand that we have this background data, that we're not just, randomly saying, okay, you don't need this, but, seeing retrospectively in studies that these patients do better. So now we're trying to say, okay, in a prospective study, so a study looking forward and starting there, do we really need to be treating these patients? And we kind of, talk about that as terms of standard of care versus, this is the data. And also emphasizing that treatment is not without risks, like as you alluded to. And so, there's permanent side effects that come from chemotherapy, from radiation. And if we don't need to expose those patients to that, then that's great.
For those of you who don't know, Allison and I do work together on a very personal level because I treat GYN malignancies. So we know each other very well. We share a lot of patients together. And I think one of the really nice things that you can attest to is that we are all so accessible. I mean, we have, world-renowned pathologists here that are running the molecular tumor board. Dr. Ross, can you tell us a little bit about what the molecular tumor board is and how that plays into patients' treatments. It's something that's, happens once a month, I think.
Once a month,
okay.
yes. Yeah, the molecular tumor board is not unlike other tumor boards in that patients are presented individually. And to a large group of physicians of multiple disciplines to enlarge the capability to have new thinking for their disease. So many of them have very serious cancers. We occasionally will present very interesting, very curable cases that just have very unusual mutations that are educational. But that's I would call the exception. More the rule is a very advanced patient in which the look is for what's the next line of treatment that might help, given the patient is progressing on the line of therapy that they are currently on or beyond, looking for newly discovered biomarkers that could select a therapy that might be only available through a clinical trial, and then recommending the patient for a clinical trial that targets that alteration, or using a treatment that is approved for another disease that you're going to try to do what we call an N of 1 clinical trial, one person, one at a time, requiring, of course, approval by all governing boards of patient safety, as well as, in many cases, approval from the patient's insurance company to allow them to have a 90-day supply of this drug that works for this kind of cancer, but has not been evaluated in the one that they have, to see whether or not they could respond. And often they do. It's not always the case that a discovered target is equally treatable in all types of cancers. Some you have to do things differently. But there are some biomarkers that doesn't matter what kind of, whether it's uterine cancer, non-small cell lung cancer, brain cancer. If you give this drug, that tumor will get impacted in a positive way and help the patient survive longer.
So essentially what you're saying is the genetic makeup or the blueprint of a cancer, right, can define which treatments will work regardless of the type of cancer that it is.
That's right. I mean, for uterine cancer, where TP53 mutation is a very ominous finding, for serous carcinoma, for example, and in the vast number of patients, we can't do anything about that. Again, I like to talk about it as driving a car. When your foot is on the gas, that's an oncogene. Drugs can take your foot off the gas to try to slow the car down. But if instead it's your foot has come off the brakes, we don't have drugs that can put your foot back on the brake, meaning restore the function of tumor suppressor genes like TP53. But now we do have, for the first time, drugs that can target TP53. Fortunately, it's a very small percent, but GYN cancer is the top place where the first drug called rizotapopt is working in about 2% of the patients who have a certain TP53 mutation that the drug can intercalate into the actual sequence of the protein and cause it to restore cell cycle suppression, which is the main normal role of tumor suppressor. It slows your cells from growing too fast and slows your cancer cells, which are growing out of control. But it is GYN cancer where the development is happening, because it, at 2%, unfortunately, it's not more frequent, is the highest of all solid tumors.
Wow. So I feel like this is an educational session for me. I'm actually learning a lot sitting here and talking to both of you. I want to take a little bit of a step back. You know, we obviously we're talking about molecular blueprint of tumors. That's not something that patients can necessarily control. One of the risk factors, though, for endometrial cancer is obesity. Allison, can you shed a little light on, what that means for us as clinicians and how we can do a better job maybe counseling patients on some of the risk factors and what they can avoid?
Yeah, so obesity we see linked with kind of the most common type of endometrial cancer, that endometrioid type. And that tends to be a hormonally sensitive type of cancer. So estrogen receptor, progesterone receptor tend to be expressed on that type of tumor. And really what we see is that risk factors for it are overexposure to estrogens in some way. And so whether that's that you got your periods early in life and you went through menopause later in life, so you had a longer exposure. But the kind of link to obesity is that you have something in the fat tissue and the adipose tissue called aromatase. And aromatase converts some of those other peripheral hormones in your body into estrogen. And so if you have excess kind of that conversion, then your body or the uterus sees more estrogen than it normally should. And that kind of triggers the tissue in the endometrium, the lining of the uterus, to start growing inappropriately. And it can, and especially after menopause, when you don't have as much regulation from the hormones, you can see that estrogen really drive the endometrial tissue to grow, and then eventually it becomes more atypical. And we see this progression from what's called atypical hyperplasia, or endometrial intraepithelial neoplasia is kind of the newer term for it. It's all nomenclature, but basically means the same thing, that you have these kind of changes in the tissue that are kind of a pre-cancer type finding. And if you left it alone and did nothing, that would eventually turn into an endometrioid type cancer. And so the estrogen exposure really drives that. And we see that link between the obesity and the estrogen. And so that's one of the things that patients, can have some control over is, diet and exercise and all the things that we always tell everybody are important for your cardiovascular health, are important for kind of, almost every part, diabetes, all that kind of stuff, also play an important role in endometrial cancer and cancer risk.
Dr. Ross, can you tell us what, if you know, I actually don't know if I know the answer to this, but do you know what percentage of like endometrioid adenocarcinomas are estrogen receptor positive?
Oh, it's quite high. It's probably, again, similar to breast cancer, in the sense that the very young women tend less frequently and tend, unfortunately, to have more poorly differentiated and non-estrogen receptor expressing tumors. In postmenopausal, it goes up significantly, just like in breast cancer it does. And so they're similar in that way. I think for postmenopausal endometrioid, I'm going to guess it's 60%,
Okay.
Around something like that. And again, the receptor test, which is an immunohistochemistry test, where the pathologist applies a antibody stain on the slide and looks at it under the microscope. It's very easy when it's completely negative and obviously positive, but when it's very low level, it can be controversial about what the cutoff should be, when you should call it a positive, uterine ER positive tumor, and when you shouldn't. So it's not always straightforward, the actual decision as to which it is. And of course, one thing we haven't talked about is the role of predisposition in the patient's inherited germline, and how important that is also for gynecologic cancer patients, not only for their own treatment, but for the screening of family members should a germline test be positive.
So you mentioned germline testing. There's a syndrome, and I want to just highlight, there are certain things, obviously patients cannot change. So what is are the, familial, germline mutations that you're talking about that could predispose people?
Well, for endometrial cancer, it's similar to the mutations associated with colorectal cancer, sometimes known as the Lynch syndrome, although you can have the uterine predisposition without the other features of the Lynch syndrome, so it varies. But pathologists will do immunohistochemistry stains to look for loss of proteins that are expressed in tumor cells that we call stable, microsatellite stable, and that will rule the Lynch syndrome out. But if the expression of those are lost, and this can also be diagnosed with a sequencing assay, that raises the possibility of Lynch syndrome. And the best way to confirm the syndrome is to do a germline test, meaning the patient has to submit to having a blood draw to get the white blood cells, which we know are not cancerous in that patient, and have the DNA that was inherited from their mother and father. And that can decide whether or not it's Lynch syndrome associated microsatellite instability, which changes all sorts of treatment plans, or whether it is Lynch syndrome associated, which then has to lead to familial counseling.
So I have actually been down to a pathology lab before. And I know that you guys have really cool automated things that, can sort of do all the staining that you're talking about for you. But what about actually reading those slides and looking at, the percentage of cells that are positive for estrogen, progesterone? Are there computer systems that do that? Who does that? Do you look at the microscope and count one by one?
Sure. I mean, it varies from institution to institution. How much is automated and digital and how much is analog and the pathologist just looking in the same way they look to make the diagnosis, counting up how many nuclei have stain and how many don't, and saying it's 10% positive with no impact of how intensely it's positive, just any positivity, versus not only digitally imaging the slide so it becomes a digital file, having a system that's been designed with the software to analyze for hormone receptor positive, or even the microsatellite, which are nuclear stains as well, or even going beyond that to an actual AI system that does the entire thing and produces a report. Today, we don't have follow-up data that the AI systems are better than the human pathologist at reading these slides.
So you still have jobs then?
Yeah.
I'm just kidding.
Yeah, I mean, for the time being, maybe someday it's an AI system doing even the original diagnosis, to say nothing about the follow-up testing. But for right now, it's still a human pathologist who's interpreting these and making the decision.
And the other thing, this was talked about on the first episode, but I think there's a big misconception around how much effort, money, time, you name it, goes into kind of scaling up these technologies to make these available to people in the US. Just the US, everywhere in the world would be great, but not even everywhere in the United States has some of these testing capabilities, right? So what are some of the things that go into implementing them and scaling up per se?
It really varies from region to region, site, small town versus large city. There are, like Foundation Medicine and other companies that also do gene sequencing for cancer patients. Guardant, Tempus, and Caris. Is it Cirrus? Caris are three other examples. So you have to choose which way. It's very sophisticated and challenging. And you don't want to make a mistake because it's the patient's, in some ways, last chance to find a new therapy that can really make a difference. But that said, I think the bigger problem is that not enough of it is done, and a lot of patients who could benefit. And remember, a lot of these cancers are not curable, but with the right biomarker detection and the right treatment personally designed for them, the amount of months or even years of continuing survival is critical, because they get to weddings, they get to graduations. And while that's happening, doctors like Allison are doing clinical trials of new agents that weren't available when they were diagnosed, who they now qualify for. And then more years can be added. And this is kind of the goal of it. It's converting what I would call acutely fatal cancer into a chronic disease the patient can live with. But the big problem is there are not enough Allisons and you. There are not enough seats in the waiting room, because if this year's cancer patients don't succumb from their disease as last year's did and want to come back to the office for more treatments, but the new patients are being diagnosed just as always, we're going to overload our medical capability to treat our cancer patients. Our success is going to create, I believe, a crisis in lack of physicians and lack of facilities.
I agree with you on that. I think, I feel personally very, very blessed, because there are places in the US, obviously, that do not have GYN oncologists. We are lucky enough here at Upstate to have 4 of them, which I think is outstanding. Allison, can you talk a little bit about what's the training involved in becoming, a gynecologic oncologist, if you will?
Yeah. So, I mean, like most other medical specialties, it's 4 years of college, 4 years of medical school. And then we go through an OBGYN residency, which is another 4 years of training. And then gynecologic oncology fellowship is somewhere between 3 and 4 years on top of that, depending on kind of research, because we all do research involved in our training, again, to kind of give us the tools to be able to participate in these clinical trials and studies. So there's, kind of a year or two of research involved with this. And then kind of the more specialties surgery that we do, getting all the information about chemotherapy, because as GYN oncologists, we kind of take care of the whole patient. So we start with, cancer diagnosis and then the surgery. And then we also treat those patients through their chemotherapy, through either, cure, or on the other side of things, through their hospice and through their palliative care kind of services too. I agree. Like even in, I've been in practice as an oncologist for 4 years now, almost 5. And even in that time frame from going from residency training to now, I've seen the improvements in patients living longer with these cancers, and it's great to see that. But I agree, it's now you need more providers to kind of take on the number of patients that are living longer.
It's a great problem to have.
Yes.
But it is a real problem. So medical students, this is a call to action. Please join oncology. I want to switch gears just a little bit, and we kind of talked about training, but what is one of the things that people don't realize that you do in your job every day? Or patients, even your family members, what's something that nobody realizes that you do at work?
I kind of alluded to it already, but I think it's kind of the caring for kind of covering all of GYN cancer, and in the sense from the surgical aspects, because a lot of other oncology specialties, you have your medical oncologist that does the chemotherapy, the kind of immunotherapy, kind of the treatment side of things. And then you have breast surgeons, you have colorectal surgeons, you have hepatobiliary surgeons that kind of do the surgical side of things. Whereas from GYN oncology, I'm in the OR every other day and in clinic every other day, doing kind of the surgical side of things and taking care of, surgical complications and that aspect, in addition to the chemotherapy, the immunotherapy, the clinical trials world. And so it's a unique balance. And one of the reasons that I actually really went into this field is because we have that kind of comprehensive care and have the kind of procedural aspect of things, which, is one of the things that drew me to this, but also that relationship with patients, that continuity that you are staying with those patients through their entire course of cancer treatment.
For pathology, this is a very easy question. The vast majority, I think, of people think that pathologists spend the vast majority of their time doing autopsies on patients who have died. And it's actually a very small portion of the training of pathologists. And in pathology practice, the only subspecialty that autopsy is the core procedure are the forensic pathologists, who are investigating a natural death, criminal settings, those types of things. The general pathologists spend a small percent of their time on autopsy pathology. It is important because that's how pathologists learn about tissues and the gross appearance, not only of cancer, but infectious diseases and cardiovascular diseases, and then get to see them under the microscope. But ultimately, it becomes way less than 10% of their time, way less than 5% of their time. Then they're now focused on what they learned looking at autopsy tissues from patients who died and applying them to patients who are alive and deciding what this diagnosis is and what's the best treatment for this disease. I think that's why in many autopsy suites or in hospitals and in other places, there's a Latin sign over the entry, which essentially says that in this room, the dead give up their secrets to help the living. And that's the definition of how a pathologist learns.
That's very cool. I did not realize that. So I think, we're going to start bringing this episode to a close. And in doing so, we talked about the shortage of physicians and, especially in oncology. What's one piece of advice you would give to, the future generation of medical students or even people thinking about going to medical school, moving forward in their career?
I would say that if you're the kind of person who wants your world to change every day, and that you want to be able to use the tools of modern information, the internet if you like, and have sources of information coming in every day that could change how you practice medicine the next day. Oncology is the field. It is changing so rapidly because of so many new discoveries occurring all over the world that an oncologist of today almost has a completely different tool set and knowledge base of an oncologist of just 5 years ago. So if that's what excites you as an investigative mind, oncology is the field.
Yeah, I mean, I have to agree with that. It's a constantly changing field, and I think you want to have that passion, that drive, in medical school, finding what interests you, what drives you to learn more, what fascinates you, because I think you need that passion to really, reflect in kind of what you're doing. And so you got to find the area, the niche that is interesting to you. And stuff that I learned in fellowship has changed even in the 5 years, since then, in terms of, how things are changing. So it's rapidly growing. We're learning new stuff every day. We're integrating new things into our practice. And if I agree, if that's what is exciting and that's what makes you passionate about it, then that's definitely a field you should go into.
All right. Well, thank you both for participating in the second episode of Pipettes to Patients. I loved having both of you on here. I learned a bunch of new things today. And I hope you guys will all join me next time. In closing the second episode today, I want to highlight a few important pieces of information. Uterine cancer is common and can be a very curable cancer. I encourage patients and caregivers alike to be mindful of the signs, symptoms, and risk factors of uterine cancer. If you're looking for more information, I suggest logging on to the International Gynecologic Cancer Society's website at www.icgs.org, as they have a wealth of information tailored to patients and clinicians. I also encourage you to join the Jump for June challenge on social media to help bring awareness to uterine cancer. Just remember to use hashtag Jump for June and hashtag UCAM in your posts. Additionally, you can pop over to our website at www.upstate.edu/cancer/research if you're interested in learning more about the current uterine cancer research that's happening right here at Upstate. Lastly, I again want to thank all of the amazing patients that have participated in clinical trials here at Upstate. We could not do what we do without you. You can find all the links that you need to the faculty profiles of our guests from today in the show notes, as well as additional information on clinical care here at Upstate. If you enjoyed listening in today, don't forget to follow us wherever you listen to your podcasts. Thank you for joining us again for the second episode of Pipettes to Patients, where every discovery brings us one step closer to hope. Until next time, stay informed and stay empowered.